Morning all, myself Shrestha Shai I have done my MSc in obstetrical and gynecological nursing. Today I will show you about the obstetrical examination. As you all know, before any procedure we have to maintain 4P, 4 preparation. That is, first we will do the patient preparation. So in patient preparation, here is my dummy, and I can say this is the mother of. We can set a scenario. This is a mother of 34 weeks gestational age, and for her regular checkups she came to PHC or any sub-center. So what should I do? First we have to confirm about the pregnancy, and then we will ask the mother and explain all the procedures of antenatal assessment, get the verbal consent from the mother. Then we will ask the mother to void or empty her bubble. Now, empty her bubble and bladder, both. Now, patient preparation has been done. We will go for the environmental preparation. For environmental preparation, as you can see, the screen is there. There will be well ventilation and light should be there. So almost environmental preparation has been done. Then we will go for the article preparation. Actually, for obstetrical examination, 3 things we will see, 3 parts of the body, that is breast, uterus or abdomen, and the vaginal area or the pelvic area. So for this today we will only see the breast part and the abdominal part. For pelvic examination or for vaginal examination, next video I will show you. For this 2 part, the article preparation, you can see only I have taken the fetoscope or peanut stethoscope and 2-inch tape, and another tray should be there for vital signs tray, and one for documentation, the pen and one pad or that documented thing should be there. Now we will do for the self preparation. For self preparation we need hand hygiene. Medical hand washing is good enough for the antenatal examination. Remove all the articles, but and fold, if you have full sleeve things, fold the sleeves. Then one watch, second hand watch should be there. Rationale we will discuss later. Okay. Now, without harming any privacy, first we will remove the breast area. We will remove the cloth from the breast area only. So, in breast area, there are 2 methods we will check. One is palpatory by palpatory method and by seam only, inspection method. So, we will do the first inspection method. What should we do? In inspection, first we will see whether the size of the breast is, the 2 sizes are same or not. Okay. Then we will see Montgomery tubercles. What are the Montgomery tubercles? Montgomery tubercles are the transformed or modified sebaceous glands. In pregnant, that is the most difference between pregnant breast and non-pregnant breast. In pregnant breast, we can see the prominent Montgomery tubercles. Where we can see? Here. In the breast, the nipples area, here in the secondary areola, you can see small white tubercular things. That is the modified sebaceous gland. No work of that, only lubricating or giving more sebum to the breast. That is the main work of Montgomery tubercle. So we have to see whether the Montgomery tubercles are present or not. Then we will see the 2 areolas. First is secondary areola and primary areola. Here we cannot see, but if you directly see in the patient or the mother, there is a distinct difference. Like one line will be there, that line will different secondary and primary areola. Primary is the lighter and secondary areola is more darker because of the melanin secretion. It will be more darker rather than the non-pregnant breast. Then we will see whether the nipples, the conditions of nipples. Nipples are flattened. It should be inverted.
Or retroverted nipple.
Not retroverted. Retroverted nipples are there. These are the conditions. Disease condition. It should not be flattened or retroverted. Not retroverted. It is not called retroverted. It's called inverted.
Inverted nipple.
So flattened nipple should not be there. There are many things. If there is any flattened nipples, we can use the breast pump before the delivery of the baby to increase the volume of the nipples. We can use the
Any other intervention? There is a flat nipple, or they putting their
because in village area the availability of breast pump is not there, so what we can do,
thread.
Not thread, it is a malpractice. We can use the bottle, boiling the bottle in not boiling in a warm water. You can put the bottle, so it will be sterilized in the plastic bottle, then squeeze the bottle and the cap area, remove the cap, and the mouth area you have to push here. You have to place here. After placing, when we release the bottle, the negative pressure will be increased. For this, there will be pressure,
Nipple will be
and nipple will be
protruded outside.
So this can be a method for flat nipple or inverted nipple.
So they have, that's a malpractice if they put a
Thread or all.
thread. The doctor putting the thread, it will be so much painful.
Painful, and there can be injury. And if it is the flat nipple or inverted nipple, we cannot see whether the nipple is cracked or not. There are chances of cracked nipple in there also. So if we put thread and all, the crack will be more increasing, and there will be bleeding and all.
So you can use the empty bottle.
Empty bottle we can use.
Okay.
Then cracked inverted, I have told. Cracked nipple we can see. Nipple abscess we can see. So these are the conditions we have to observe. If there is healthy nipple, go for the next examination. So next we will go for palpation. In palpatory method, BSE, only with breast self-examination, we can tell the mother to do herself only, or else the midwife can do. How can we will do the breast self-examination? We have to put one hand in just beside the axilla area, then putting 3 finger or 2 finger. 3 finger is good enough. So from the sternum we have to palpate like this in a round manner towards the
without removing the hand, we are circulatory motion.
In a circulatory motion, because this hand will support the breast. Then
other hand without moving,
like
circulatory.
In a circulatory way we have to palpate.
Whole circle.
Whole circle from sternum towards the axilla.
What is the abnormal findings will be?
Okay. Here we can see the accumulation of two things mainly. One is fluid accumulation and another is mass accumulation. Fluid accumulation after 12 weeks we can observe, and that is very normal because milk will be there. So fluid accumulation.
When you are putting that some milk is coming out, is it normal or abnormal?
It is normal. After 12 weeks only, there are many cases the colostrum will oozing out. That is normal, no issue. And if there is mass accumulation, this can be a signs of mastitis or anything else. Okay. So mass accumulation is the abnormal one. If there is fluid accumulation, it's okay.
What about this breast? You will come this side, or you can do this?
By doing one breast, then we will go this side, or we can use, if it is your predominant hand also, we can use.
So you can use the other hand.
Other hand also.
Okay,
like
very good. Okay.
Or else if midwife wants to go there,
no harm in that. We can come this side. Okay.
Okay. So breast is over. Now cover the breast. Very important is nowadays is the midwifery lead care unit is now conducting these all things, and maternity care, like respectful maternity care
is very important.
It's very important.
Immediately cover the.
And our government is totally focusing on
respect of the birth.
Yeah, respectful maternity care. So we have to, whatever procedure we will do, we have to control over the respectful maternity care.
So we covered immediately.
Immediately we have to cover. Another thing, because the dummy has not the pelvic area, but 2 drape sheet we need. One drape sheet for the pelvic area, another is for the abdomen and the breast area. So another drape sheet will be there in the pelvic area.
So that you can move this one, that upper.
In the upper. Okay. So now here we can use 3 methods, that is inspection, palpation and auscultation. 3 methods will be used here. So first is inspection. What we will see inspection? First thing we will see any scar in the abdomen. Scar of like any herniation scar or any cesarean section scar. So in the lower abdomen we can see these things. Next, in inspection 2 things we have to see. One is linea nigra. What is linea nigra? Hyperpigmentation throughout from the xiphosternum to the symphysis pubis.
One line.
Over the navel there will be one line of hyperpigmentation, because high melanin accumulation will be there. We can see some hair
normal changes. These all normal changes of pregnancy, physiological changes.
Okay. Then we will see the stria gravidarum. What is stria gravidarum? In the lower abdomen area, we can see the stretch marks. That is also normal. These things are normal, and in primary gravida, it is more we can see very in different manner. We can see it very broadly. Then we will do palpation. Before palpation, we have to measure one tape. We have to place over the abdomen, so we can see the girth. Taking girth is very important. During preparation only we can put this, okay, or else we can ask the mother to uplift her body. We can check this, okay. The girth should be checked.
In inches or centimeters?
Anything. In centimeter we are using basically. So in inches also we can see. Okay. Next we will see the abdominal or uterine height. What is the significance of checking uterine height is, by seeing uterine height only we can see the gestational age. In 24 weeks it will be in umbilicus, then 1 centimeter will be increased, 1 week will be there, corresponding weeks. In 36 weeks it will be in 36 centimeter. Again after 36 weeks there will be descent will be started. So in 40 weeks the abdominal height will be 32 centimeters. So we have to assess that if the abdominal, okay, I will show how to check the abdominal height. First you have to, the midwife have to rub her hand to warm the hand. Do not place the cold hand into the mother's abdomen, it will excite the mother as well as the fetus. Then after rubbing, you put your, just midwife put side of the dorsum, the lining of the dorsum and the palm to the symphysis pubis. Then we can palpate like this. When we can feel the resistance, we have to place one hand, we can remove another hand. We have removed, and now release the pressure. During palpation we are putting the pressure, now you have to release the pressure. Then
Second inch tape.
Second tape.
So we are not removing the inch tape which is down, so it will not hurt the mother.
Hurt the mother, and again we don't have to ask the mother to uplift her
discomfort.
This is for the comfort. Then we can use this over the navel. Here also where the resistance we can feel, here we can feel the resistance. So the resistance area is the symphysis pubis. So from the xiphosternum or from the xiphosternum where we can feel the resistance, from that to the symphysis pubis over the navel is the fundal height we are checking. Okay. So here we can see fundal height is 31 centimeter. Now we have to concentrate whether the gestational age of the mother, whether the baby has been in descending mode. If it is in descending mode, the 31 centimeter or 32 centimeter will be corresponding to 40 weeks. Or if the baby is not in descending mode, the lie is not stable yet, baby is moving around, then we can tell if it is 31 centimeter, the gestational age is 31 weeks. Is that clear?
Okay.
Okay. So now you can see I didn't remove that hand.
Still the hand
is there. Now we will see the 4 grips. So for this we will put this hand also, and here you can see my face, midwife face is towards mother's face. Okay.
And the position also.
And position also should be maintained. One leg will be our left leg will be in front of us, and we can push. We can give all the pressure towards this leg. So here we can see, we can palpate, and by palpation grip method we can see the position of the fetus, the lie of the fetus, as well as the presentation of the
Three things you can see.
Three things we can see. So here we can see that in the palpatory method the irregular broad mass is being filled. So we can tell it is the buttocks area or the podalic pole of the fetus.
If it is a head,
Then a small globular and hard mass will be felt. Okay. So now without removing that is very important, without removing the hand, one hand I can place here to support the fetus, another hand again we can palpate. And as we can see the curvature here, the curvature is being felt by palpation. We can conclude that it is the spine of the fetus.
so all these things with the support of the
Another hand. One hand should not be removed. And during all the grips assessment, the hand should not be removed. Okay. Then
So this palpation is a lateral
palpation.
So
This
what
is
you've done with the frontal is finished, then
lateral, coming to lateral. Then again place this hand, support this hand, and we have to palpate this. So here in this we can see this is the fetal spine, because one curvature I have seen and small irregular muscles I have seen here. So this is the limbs we can say. So by these two method grips only.
What is the line now?
Now it is in a anterior-posterior line, not in the lateral line. So by these two methods we can assess the position, not position, the presentation of the fetus and the lie of the fetus. Now for position we have to go like this. We cannot remove our hand, so our hand will be like this.
You are moving. Hand
I am
is not moving.
Only I am moving and I have to face towards the mother's leg.
Okay.
Then this is the grip of this is the pelvic grip we are doing. So by placing my hand is placing like this, we have to palpate like this. If
Both the hands are moving towards the symphysis pubis.
If my hand will goes like this, that means the head has not been engaged yet. That means the head is been engaged. And if my hands is going like this, that means head is not engaged yet. So we can see after finishing the lateral grip in pelvic grip, my hands are going like this. So it is not engaged yet. So next grip is Paulic grip. As it is not engaged yet, we no need of assessing Paulic grip, because in Paulic grip what we are assessing the stations and whether the head is movable or not. Here we can see head is movable.
So you cannot. So since the head is movable, no need to go for
the Paulic grip. If head is been here, we can see head is
So this
engaged.
is called pelvic grip 1.
This is pelvic grip 1. This is the Paulic was the 2.
Paulic 2.
Then if the head is been engaged, my hand is going like this.
Then what will you do?
Again we have to
Come like
this.
this. Without removing the hand.
Remove one hand, then hold the fetal head and assess whether it is moving or not. Here,
During the time, what is the leg position of the mother?
Mother
Will be folding the leg, or normally will be leg lie down only?
No issue. If we can tell the mother for the lithotomy position, or otherwise we can say the mother for the normal.
Is it no rules that lithotomy bending their knees? No need.
No need. Then we have to hold in this grip only in Paulic. We have to hold the head in this manner and assess whether the head is moving or not. If head is moving, engagement is not there. If head is fixed, means engagement is there. So we can assess. In this case, we have to assess the ischial spine. So ischial spine, how can we assess? We can in this manner. Here we can see the resistance. Whether resistance or bony prominent area we will see, that is the ischial spine. If the head is in ischial spine, that means it is station 0. If it is above that, that head will be movable. Okay, that will be -1, -2, -3 like this. If it is beyond the ischial spine, that will be +1, +2, +3 like this. So by Paulic grip we can assess the stations also. So grips are over right now. Now we will see, as in lateral palpation only, lateral grip only, we have seen the curvature of the fetus, and in Paulic, here in frontal also we have seen, here is the buttock, here is the head of the fetus. So in placement of the fetoscope for auscultation of the fetal heart sound, where we have to place, here is the greater trochanter and here is the symphysis pubis, and here is the head. So we have to draw a imaginary line from the greater trochanter to the symphysis pubis. So here is the imaginary line, and that imaginary line should be placed over the curvature. So in that curvature where the imaginary line is cut up, we have to place the fetoscope there.
Can you show the imaginary line again?
Here is the greater trochanter, here is the symphysis pubis, and here is the curvature. We know in the symphysis pubis only the head is there, fetal head is there. So from the greater trochanter to the symphysis pubis, there will be one imaginary line.
Then?
That imaginary line cuts the curvature here.
Yeah.
So we have to put the fetoscope over here. You can remove this. Midwife can go there if here is the auscultation point. And the position here it is not LOA, it is ROA. Okay. Normal positions are ROA and LOA. If it is LOA, it should be placed here.
Okay.
As the position is ROA, right occiput anterior, we have to place here. Before placing, we have to warm this because it can be cold. As it is in plastic, it is not cold. But if it is in steel, it can be cold. So we have to rub it to not to excite the fetus because it is a non-stress test as we know. So placing here, your ear will be in the earpiece. I have to go there.
Come.
Then your ear should be there. Remove your hand, listen it with the watch. Okay, so I can see this and watch is there.
How long you will see?
Before we have to see it for 1 minute total. Now we can see for 30 minutes, 30 seconds, and we can double it up. Okay. One more thing we can see for uterine shuffle to distinguish with the uterine shuffle and the fetal heart rate. We can palpate the mother's pulsation also, and we have to accumulate with the fetal heart sound and the mother's heart sound or mother's pulse. So in another hand, by placing this, another hand we can see the mother's hand like this, and our watch should be there in second hand watch. Now remove the fetoscope and cover the mother. All the abdominal examination has been done. We will go for the pelvic examination. In pelvic examination, there is no need of any introducing things. Only we can see, only we can inspect. If there is any signs of oozing out or show, if there is signs of show or any infection or anything oozing out, any lubrication is there from the vagina, then only we can perform the pervaginal examination.
So next class we will see the.
Next class we will see the pervaginal examination.
Thank you.